So this is just the information on CMEs that you can get from Rana if you have any questions. I do not have any financial relationships or arrangements with any of the content that's going to be covered today. What I'm going to be talking about is two things that go hand in hand: the stages of change model and then the spirit of motivational interviewing. And that's sort of the foundational component of a way of interacting with people using a motivational interviewing style. So we're going to talk about the core concepts of what's called the Transtheoretical model of change and its specific components and when you should use it, because it can be very helpful to the population that we're working with to be able to use this model to know what interventions make sense when for people. We're also going to talk about understanding how MI has kind of come about, specifically how to apply the guiding principles of the spirit of MI, which is sort of the basic components that can be applied to any clinical setting with minimal training. Of course, if you were going to do full motivational interviewing, you'd want to go on to get additional training. This would just be a basic overview of the foundational components of that. So let's start first by talking about the stages of change model. So why is it important to know this model? Why should you use it? Well, it is called the Transtheoretical stages of change. We often just call it stages of change model. It is an evidence-based model, which means that it's been researched extensively, and it's been shown to be highly predictive of telling us where a person is at and then matching it to what they're going to need or what they're going to benefit from in treatment. So it helps us to determine how best to intervene with someone rather than using sort of the same basic approach for everybody. It is not part of motivational interviewing. It did evolve separately. It's a different set of researchers that developed this model, but it fits very nicely with MI. So you can use it with or without using motivational interviewing. Really, it's not so much of an intervention as it is a way of assessing and then linking to intervention. So these are the different stages. There's a couple different ways that this model is represented, with relapse either on the outside of the cycle. I personally like to have it where it's represented on the inside, because a lot of the more current literature says that relapse is the rule rather than the exception. And so it's helpful to include that when you're working with patients conceptually, and also with educating them on what could happen and how to deal with a relapse or even a slip before it becomes a full relapse, and then to move back into a stage of change that's the most effective place for them to be at. So you can think about this as sort of an upward spiral, or like a spiral staircase that people are walking up. Even though they might go through this cycle a couple of times, they don't always start at zero. They don't necessarily take steps backwards. They bring the different skill sets that they've learned over the course of time with them as they move through this. And you can, if it helps to kind of destigmatize, sort of take this out of the land of substance abuse for a moment and just apply these stages to change in general. So for any of you that have ever tried to start a new diet or lose weight or start exercising regularly, or maybe go to visit your family once a week, anything that you've tried to change that was a habit, you've probably moved through these different stages. So there's a couple things to keep in mind, and I'm going to talk about each one of them specifically. But not everybody goes through this in a linear way. So not everybody starts at the beginning and then ends up at the end in maintenance. People can skip around, or sometimes they'll move through, they'll get to maintenance, which is where we've made the change and we're sustaining it. And they might go backwards a few steps rather than all the way to the beginning. So that's just important to consider, that even though it gives us some predictable patterns, not everybody moves through that in a linear fashion. So what are the things that we're wanting to look for? Well, this is how the stages go in order. So the beginning of the stage is pre-contemplation. And so that's for individuals where you're not really considering a change in the foreseeable future. So that could be that it doesn't necessarily mean you're in denial. It doesn't mean that you're unaware of the fact that change is needed, but you're not considering doing that. And there could be a lot of different reasons why you're not considering that. So it could be, so for example, let's say you go to, you know that you're a little overweight and you'd like to lose weight, but maybe it's just not feasible for various reasons. So you're not planning it, you're not thinking about it in that way. You're aware that it's a problem, but you're very securely in pre-contemplation. Contemplation is where you're considering making the change in the foreseeable future. So you're saying, I'm going to start that for my New Year's resolution this year. That's in 2 months. I'm gonna plan ahead for that. Now I'm firmly in contemplation. Preparation is where we've actually made the plan for the immediate future. So not 2 months out, 6 months out, but next week, tomorrow. That's preparation. And then action is where you've implemented the change. So that's where today is the day where I ate my salad and I walked for 2 miles. So I've actually implemented the change, then I'm in action. Maintenance is where I've maintained what I changed in action for a period of time. And that period of time has a range to it, but it's essentially that period where you're practicing that change behavior regularly and starting to shift that habit. So how this applies to substance use disorder or the patients that we work with is helpful to determine which stage somebody's at, because how we interact with them may vary depending on the stage. So for instance, if somebody is identified as being in pre-contemplation, again, they're aware this is a problem. Everybody that seeks out any kind of treatment for substance use disorder is aware that they have a problem, or they might be rejecting it because of stigma, but there are consequences associated with their use. So the problem is clear, but they don't necessarily see a way to change it, or even have the willingness to change it at this point in time. So us pushing on that, or trying to convince them or give them facts or figures about how their behavior is problematic, is not necessarily going to help them in that moment. They are going to be in a place to push against those types of interventions. So what's recommended for people who are in pre-contemplation is just to focus on building the alliance, helping people to really think through what is working for them and what isn't working for them, and just sort of staying in that space. You can begin to use the spirit of MI, but MI wouldn't necessarily be recommended for people in pre-contemplation. People who have moved into contemplation, which means they're ready to do it in the foreseeable future, that's where MI has its most efficacy. So we're really going to start to use the techniques of MI when people are firmly in contemplation. They're in pre-contemplation and we go right into using the Socratic method and applying some of the techniques from MI. We're probably not going to be as effective as if we just focused on maintaining the alliance and assessing for what's important to them right now, using good harm reduction, how can they stay as healthy as they possibly can today, right? That's our focus. Then we're not engaged in that kind of arm wrestling. Once they've moved to preparation, you no longer want to do motivational interviewing because that's where people are taking the steps. We're gonna do this in the next couple of days. They're actively in the process of change. They don't need motivation to change. And where some people go wrong is they learn the techniques of MI and they get really excited about it and they apply it to everybody. And unfortunately, once people have moved into preparation, you can cause them to take some steps backwards, because we start to kick up ambivalence that maybe they've already moved through, and they start thinking like, well, maybe I'm not ready. When in fact they were in planning and all we had to do was just support that. We just had to be like, okay, what's the plan? So that's another reason why it's important to know this stage model, so that we're not applying the wrong things at the wrong time. Same thing when somebody's in action, we don't really need to do anything but help foster their self-efficacy and maybe start to build those relapse prevention skills, which we're very firmly gonna assist them with once they've moved into maintenance. Because once somebody's made that hard turn into initiating some change behavior, maintaining it is usually where the rubber meets the road, is the expression, right? That's where the difficulty tends to show up, is how do I now maintain this change behavior? So when a person's in pre-contemplation, We really just need to help them sit with that and support them. So our goals are to bring awareness to the problem as it surfaces so that they can really start to think about what they are willing to do or what they're not willing to do, address any barriers that might be preventing them from thinking about moving forward. So our jobs are to listen to concerns, reflect content, elicit past experiences of success, current strengths, current attitudes. So why would you want to do anything differently? And then communicate that we accept them for where they are. So that way that rapport is very firmly there. Once they're in contemplation, this is where we're going to start to implement some motivational interviewing. And our goals here are to keep them talking about change in a very strategic way to boost their awareness of their change options and to really boost their perception of the benefits of change. So moving away from what's called sustained talk, which is talking about why they shouldn't change, to the benefits of why they should, and what are their reasons, what are the values that really support that. This is where it can be helpful to do, it's called develop discrepancy or a decisional balance, where we're helping them to reflect that ambivalence, the part of them that wants something different and the part of them that's really scared about doing something different or isn't completely sure that they're going to be successful if they try to do something different. Exploring where change behaviors line up with what's truly important to them, their values and their goals, and then reflecting that intention that they want to make this change for their family, for their children, for their future, right? That why that's important, and really clearly identifying and spending significant time there, because that can get easily lost on a day-to-day basis when people are really struggling with urges and cravings to use and triggering situations. We want to help them address a discord that could arise. And so that means, you know, we want to really avoid when people are in contemplation, what I'm going to talk about here in a minute, which is the writing reflex. Anything that is going to push people to start arguing with you or defending the status quo. So it can be helpful to be very thoughtful about the language that you use with somebody who's in contemplation. This is a fragile state that what we say could have a lot of influence. So an easy shift in your language that I encourage you to think about is to go, when you're having conversations with people, to, if you hear yourself say yes, but, that's arguing statement. So you're validating, yes, but have you thought about this? Or, but you're still not doing X, Y, and Z. If you're using that we enter into an argument or a persuasion tactic right away that will put people on the defense. Versus if we just shift that one word to and, we can have a much more conversational approach to helping people be thoughtful with what they're doing and that they truly have autonomy in these decisions. So going, yes, I completely hear what you're saying, and it's still, and fill in the blank. So you're acknowledging both things can exist with their ambivalence, that they want to make the change and it's really hard, right? So that's a much more validating approach to what's going on. Because what we're trying to do is support their self-efficacy. Change is extremely difficult and people can get demoralized really quickly. And so helping them to see, you know, what have they done in the past that they've been successful with? How can they maintain their optimism, their commitment, what intentions they've set for themselves, and that they truly do have decision-making ability and autonomy to make these choices. When somebody's in action, we really don't have to do much here. Again, we pull away from some of those MI approaches because we don't want to put people backwards. We just need to encourage progress, identify and help to eliminate any barriers that could get in the way of applying the change that they want to make, and then help them to scaffold successfully. So some people want to like bite off a whole bunch of change right away. And that's great intention wise, but implementing it can be difficult. And so helping them be thoughtful for how can they be successful with what they want to do this week, right? What's the small change this week, and then build on that for next week. So they just keep making these what's called successive approximations toward the ultimate goal of what could be sobriety or could be employment or could be, you know, a larger big picture thing. What are the small steps that they need to take? That's what you're doing in action. And just quickly, I mentioned earlier that relapse really is the rule rather than the exception. And so it's helpful to talk to people throughout as they move through these stages throughout the course of recovery, that it's not a sign of failure. And in fact, how we talk about relapse can really have a profound effect on how people move through it. We want to normalize that this is a common thing that happens. It's part of chronic illness management. Substance use disorder is a chronic condition. And so it's going to probably come up at some point in time. It doesn't mean that they've failed. It doesn't mean that they start over. It's just, okay, there was that, let's learn from it. It was a slip. How can you help them to avoid being discouraged and re-engage in what is going to help them be successful? What is it that they were doing that was helping them stay on the track that they wanted to stay on? So it's not a win or lose situation, helping them see it as a learning opportunity. And that's why it's important to talk about relapse right at the beginning. So now I'm going to move into talking about the spirit of MI, which, like I said, you can use this throughout any of the stages, but it's particularly important for people that are in contemplation that we're absolutely applying the spirit of MI. This is a quote that comes from 1660 that I think is still very much appropriate to today. People are generally better persuaded by the reasons which they themselves have discovered than by those which have come to the mind of others. And this is very much true for human beings, that we will take in information and advice and listen to other people, but it is not nearly as helpful as when we have said it in our own mind that that's what we want to do. So that's what motivational interviewing is set up. It is something different in the sense that it's an effective way of just talking with people about change. That's all it is. It's collaborative and allows the person that's using it to guide someone to elicit their motivation for change and strengthen that motivation. It's not going to get someone to change, right? It's just partnering with the part of them that already wants to do it. So that's why it's only really effective when people are in contemplation, because that ambivalence is necessary for this style of conversation to have effect. If somebody doesn't have the part of them that wants to make the change, then this isn't going to be a helpful conversation, right? They have to have both minds there. I'm not going to go through these, but you'll get the slides. This is just a moment to pause and say MI is highly research-based. There have been thousands of studies that have been conducted, numerous meta-analyses. When it is done at the right time, it is highly, highly effective. So there are numerous components to motivational interviewing. Spirit is the foundational piece. So that's what everything builds on. So there's spirit, there are specific principles that go along with MI. There are processes that you would follow, and then that's followed by some skills and techniques. So there are components that are actual technique driven that you would need to get additional training to learn if you haven't already. But the foundational piece is the spirit. And I would say that this is the one that takes us the most practice with. We can learn the skills and techniques, but the spirit piece is so opposite to how we're traditionally taught and how we are with our friends and family and our kids, that it really kind of pushes against what our default would be. So people have a tendency to drift away from the spirit, even though they really believe in it, if you're not practicing it every single day. So what are some components of the spirit of MI that we have to absolutely be thinking about all the time? Number one is we have to appreciate the role and the importance of ambivalence. So I've already mentioned that it's really feeling just two ways about something. It is not a lack of motivation. And in fact, that when we sense that ambivalence is there, any resistance to change, that's not a bad thing. We can work with that. It is a normal part of the change process. And it is necessary for any habit to shift. That ambivalence has to be there. So our only role is to welcome and honor ambivalence and to avoid what's called the communication trap. So that means getting into an argument with someone where we're arguing one side. What are they going to do? They're going to defend the other. And that is a natural thing. If anybody has ever had a conversation with you when you've been thinking about wanting to change something, diet, exercise, family involvement, going back to school, anything you can think of that you've wanted to change, and they said, you should, you need to, you have to, and use that language, you probably didn't feel as motivated after that conversation. So that's the communication trap, where we get into so naturally, we start to tell them what they should or need to do. They will naturally defend the status quo and be less likely to change, even though a big part of them wants to. So what are we trying to do? Avoid that natural inclination, which is called the writing reflex, because as soon as we start falling into that trap, telling them what to do and how to do it, without actually talking to them about why it's important, we're going to create that resistance. Why is it here? Well, I think as helping professionals, we fall into this communication trap because we believe that they don't see the problem. That's that old concept of denial. They don't know how to change it. They don't know that they need to change it, or they just flat out don't care. They're in some space where they don't care about making a difference. So we think all I need to do is to give them insight, give them knowledge, or give them skills, and they'll change. But that's not really true, because that's not how people change. So when we're coming at people with the writing reflex and they have ambivalence present, so they're in that contemplation stage, it's going to be like worlds colliding. It is going to feel like you're having an argument. So what happens when we fall into that trap? Well, it depends on the patient. Some of them are going to make the change briefly just to, try to satisfy us. They want to be good patients. They're going to try, but they're probably not going to be successful long term. They might listen politely, but then just proceed to do whatever they're going to do. So they may think, oh yeah, I'll definitely do that. But then we don't see any change. They might actually push harder and argue with us. But at the end of the day, no one benefits. And unfortunately, we have a tendency to blame the patient and say they're not motivated. Or I hear this one all the time, they're just not ready. Right? And so that's probably because we've fallen into that communication trap. So a couple things to keep in mind with the writing reflex is the rule. And this is part of the spirit. So this is number one, resist the writing reflex and do these things. Try to understand your patient's motivations. What is their why? Because that's a worthy conversation that will get you out of that communication trap. Listen to them, their values, their goals, what's important to them, and then look for opportunity to empower them. Because remember, the number one reason why people don't change when they're in contemplation isn't because they don't know how, or isn't because they don't want to, it's because they lack confidence in their ability to. So empowering is always a good place to go to. And one of the things that we can use as an option to really helping empower our patients is to use what's called the ACE rule. So really focusing on applying the spirit of MI by giving acceptance, collaboration, and evocation to everyone we work with. And so when we're doing acceptance, that means that no matter what's going on, as long as they're not hurting themselves or someone else, and we need to intervene directly with those problematic behaviors, we're going to accept them as being okay for exactly where they are and who they are. And so that means conveying and communicating a sense of absolute worth, providing them positive regard, which is an absence of judgment of their behaviors, and always providing respect and encouraging trust between us, regardless of their behaviors. So when people experience this level of acceptance, then they feel free to change, because then they're outside of that trap of needing to defend the status quo. It's kind of an amazing thing in MI literature where they found that when people really truly experience positive regard, which doesn't happen that often in the world, they make decisions towards health and their own personal growth and benefit, regardless of any other interventions that are provided. So if at a minimum, what we do is accept them, that's a pretty big deal. Another part of acceptance is providing accurate empathy, which means striving to understand someone else's perspective, meaning, and values. So really having conversations about those internal experiences. And then again, supporting their autonomy, acknowledging that they do have the freedom to make choices and that their attitudes and behaviors will be respected and affirmed, that we appreciate who they are, their strengths, and the efforts that they're making, no matter how small. Even just showing up is a huge effort that can be reinforced. The next one is collaboration. And so that's just recognizing that a lot of what we're doing, We are not the expert. They are the expert on their own life. So we're an active collaborator rather than a provider of something in this mindset. So we're exploring instead of persuading, or we're dancing instead of wrestling. And that what we're doing in these conversations is for them, is with them, not for them, right? So that's a slightly different shift from traditional medicine and interactions. That they are the undisputed expert on themselves, and that they know when and how they need to change. They often don't need help with that part. They just need some of that reinforcement and that unconditional positive regard. And then lastly, what we were aiming to do with the spirit of MI is evocation. And that's where we go through a communication that we recognize that they have what they need. Our goal is to just try to evoke it, to bring it forth. We're not giving them something that they don't have. So that motivation is already with them. Remember, if they're in contemplation, they already have the motivation to change. They don't have to wait until they're ready, this magical state that pops up, that we can evoke that. And that's actually part of our job, that when we say they're just not ready, it could be that they're not in contemplation. That could be it. They're in pre-contemplation. We're not going to do this work. But if they're in contemplation, then that's on us to focus on evoking those strengths and those motivations, and having a really thorough conversation about their why. Why do they want to change? And trying to understand their perspective. So treatment without MI feels a lot like this, versus treatment using the spirit of MI feels a lot like this. So that's, in a nutshell, those two concepts that we wanted to discuss. And that's all I got.